Madam, we are live now. Shall we start? So, good evening, doctors. I Shumon on behalf of Shield Healthcare, welcoming you all today in another interesting session on decoding vaginal microbiome. And our guest speaker is Dr. Ramya, krishna, jasty, madam. Madam did her MBBS from Guntur Medical College, DGO from Asram Medical College, and infertility fellowship she got from UK, and she is practicing in Sri Krishna Hospital, Chilikarulipet, Guntur, Andhra Pradesh. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation, and please post your queries on the Q&A dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time in our platform. And over to you, ma'am, for further proceedings. So thank you very much.
Thank you very much for the introduction, sir. I am Dr. Ramya Krishna, practicing gynecologist since last 7 years in Chilikalurpeta and practicing infertility treatments from last 3 years. And today I am here to discuss with you all the most important and common complaint which we see regularly when in our OPDs is vaginal discharge. To decode what is the main pathology leading to their complaints, we have to understand from the basic point like what are all the normal vaginal flora so that we can clearly understand their pathology and what makes the pathogenesis and what are the different types of vaginal discharges and what are the pathogenic organisms, how to decode them and how to treat them. Today we will see everything step by step. Today's my topic is decoding vaginal microbiome. Normal vaginal flora. Many different bacteria usually inhabit the vagina. Example, lactobacilli, which excrete hydrogen peroxide, creating an acidic environment, which is a natural disinfectant that acts to maintain the normal balance of the organisms in the vagina, that is hostile to disease bacteria. Any condition that changes the vaginal acidity or disturbs the normal bacteria in the vagina may predispose to an infection. There is a delicate balance between the two major microorganisms normally found in the vagina of women during their reproductive years. These microorganisms are Candida albicans, which is a type of yeast, and Lactobacillus species, which is a type bacteria. What is the normal ecosystem that is prevailing in vagina? Estrogen levels and pH in vagina should be maintained between 3.5 to 4, and the normal vaginal flora containing Lactobacillus acidogenic corynebacteria. What is the definition of vaginal infection and vaginitis? Vaginal infection is overgrowth of bacteria which is normally present in the vagina. Vaginitis is inflammation in the vagina. What are the types of vaginal infections? Types of vaginal infections, they are divided into 3 major factors depending upon the causative organism. Mainly they are bacterial vaginosis, trichomoniasis and candidiasis. Bacterial vaginosis is caused by overgrowth of Gardnerella and gonococci. Trichomoniasis vaginosis is commonly caused by Trichomonas vaginalis, which is a parasitic or protozoal infection, and candidiasis. Fungus and Candida albicans are the responsible candidates for candidiasis. So, vaginitis is usually characterized by a vaginal discharge and or vulval itching, irritation, and a vaginal odor may be present. The 3 diseases most frequently associated with vaginal discharge are bacterial vaginosis, trichomoniasis, and candidiasis. Various diagnostic methods are available to identify the etiology of an abnormal vaginal discharge. The cause of vaginal symptoms usually can be determined by pH and a microscopic examination of fresh samples of the discharge. Laboratory testing fails to identify the cause of vaginitis only in a small minority of the women. What are all the risk factors leads to these infections of the vagina? There are few commonly seen risk factors. They include poor personal hygiene, obesity, using too much of the soap and detergents, and uncontrolled diabetes, wearing clothes that are too tight, and use of feminine deodorants, douches, and scented sanitary products, and excessive use of antibiotics and hormonal contraceptives, stress, change in sexual partners, unprotected sexual intercourse with someone infected with sexually transmitted diseases, pregnancy, recent childbirth, or menopause. Inadequate sleep and nutrition are also the risk factors. Now we will see clearly the what is bacterial vaginosis in detail. Bacterial vaginosis is the name of a condition in women where the normal balance of bacteria in the vagina is disrupted and replaced by an overgrowth of certain bacteria. It is sometimes accompanied by discharge, odor, pain, itching, burning. Bacterial vaginosis. Bacterial vaginosis is a polymicrobial clinical syndrome resulting from replacement of the normal H2O2 producing lactobacillus species in the vagina with high concentrations of anaerobic bacteria like Provatella species, Mobilinca species, Cardinella vaginalis, and Mycoplasma hominis. Bacterial vaginosis homogeneous. Trichomonas vaginitis. Trichomoniasis is caused by the protozoa Trichomonas vaginalis. Many infected women have symptoms characterized by a diffuse, malodorous, yellow-green vaginal discharge with vulvar irritation. However, some women have minimal or no symptoms. Trichomonas vaginitis shows following signs and symptoms. About 50% of the women infected with trichomoniasis do not have any symptoms. The severity of discomfort varies greatly from woman to woman and from time to time in the same woman. Symptoms can be worse during pregnancy or right before or after a menstrual period. Principal symptoms like persistent vaginal discharge, which has the following features like profuse, extremely frothy, greenish, foul smelling discharge, vaginal itching, irritation, and pain. Patchy redness of the vagina, including labia and vagina, can be seen on external examination of the patient. Frequent painful dysuria, if urine touches inflamed tissue, is one of the symptoms. Generalized vaginal erythema with multiple small petechiae can be seen frequently in those patients. What are the features of vulvovaginal candidiasis? Vulvovaginal candidiasis usually caused by Candida albicans, but occasionally is caused by other Candida species or yeast. An estimated 75% of the women will have at least one episode of vulvovaginal candidiasis and 40 to 45% will have two or more episodes. On the basis of clinical presentation and their microbiology, host factors, and response to previous therapy, vulvovaginal candidiasis can be classified as either uncomplicated or complicated. Approximately 10 to 20% of the women will have complicated vulvovaginal candidiasis, suggesting diagnostic and therapeutic considerations. Vulvovaginal candidiasis is characterized by the symptoms like pruritus, vaginal soreness, dyspareunia, external dysuria. None of these symptoms is specific for vulvovaginal candidiasis. Abnormal vaginal discharge. White, curdy-like, cheesy vaginal discharge is the specific symptom. Vulvovaginal candidiasis. Uncomplicated vulvovaginal candidiasis is it has the following characteristics. It is sporadic or infrequent vulvovaginal candidiasis. The symptoms are mild to moderate, likely to be Candida albicans, non-immunocompromised. Patients visit. Complicated vulvovaginal candidiasis is commonly recurrent vulvovaginal candidiasis, severe vulvovaginal candidiasis, and non-albicans candidiasis, and women with uncontrolled diabetes debilitation or who are on immunosuppressive drugs and those who are pregnant. What are the symptoms and signs? In addition to itching, burning, and redness in the vagina, other symptoms include a consistency of vaginal discharge and the color odor. Consistency of vaginal discharge in bacterial vaginosis is thin. In trichomoniasis, it is frothy. In candida, it is thick cottage cheese appearance. The color of the vaginal discharge in bacterial vaginosis is gray-white. In trichomoniasis, it is yellow. And in candida, it is white in color. Odor. Fishy odor in bacterial vaginosis, fishy odor in trichomoniasis, and no odor in candidiasis. Dysuria and dyspareunia mainly absent or if present also they are mild in bacterial vaginosis. In trichomoniasis, the dysuria and dyspareunia are present and they are severe. In candidiasis also, dysuria and dyspareunia are present. Other symptoms and signs include strawberry shape of the cervix in trichomoniasis and discharge stick to the wall of the vagina cervix. Blood will appear if try to remove the white curdy material from the vagina. Diagnosis of vaginal infection. By history, bacterial vaginosis, discharge bad odor like a fish's odor, possibly worse after intercourse. Clinical examination shows discharge is thin and gray-white, color gray-white. Trichomoniasis, frothy discharge, bad odor like fishy, pain during urination, yellowish green discharge is most commonly seen. In candidiasis, history, patient will tell itching, discharge clumpy, white, cottage cheese appearance, clumpy white color. Diagnostic considerations for bacterial vaginosis. Bacterial vaginosis can be diagnosed by the use of clinical criteria or gram stain. Clinical criteria require three of the following symptoms. They include homogeneous, thin, white discharge that smoothly coats the vaginal walls, presence of glue cells, epithelial cells with borders obscured by small bacteria is called glue cells, which can be detected on microscopic examination. pH of the vaginal fluid is greater than 4.5 and a fishy odor of vaginal discharge before or after addition of 10% KOH can be observed. That is called Whiff test. For mixed infections, Gardnerella is the major bacteria involved and can be identified by the formation of glue cells. Trichomonas vaginitis. Diagnostic considerations include diagnosis of vaginal trichomoniasis is usually performed by microscopy of vaginal secretions, but this method has a sensitivity of only approximately 70% and requires immediate evaluation of wet preparation slide for optimal results. Culture is the most sensitive and specific commercially available method of diagnosis in women in whom trichomoniasis is present. Vulvovaginal candidiasis. Uncomplicated vulvovaginal candidiasis. Diagnostic considerations in uncomplicated vulvovaginal candidiasis is based on clinical features like external dysuria, vulvar pruritus, pain, swelling, and redness. Signs include vulvar edema, fissures, excoriations, thick cutty vaginal discharge. Demonstration of candidal mycelia either through a wet preparation using saline 10% KOH or gram stain of vaginal discharge. Demonstrate yeast or pseudohyphae. A culture or other test yields a positive result for a yeast species. Normal vaginal pH is usually less than 4.5. Ground staining of the fungi. Candida albicans, the causative agent of vaginitis, shows hyphae, chlamydiospores, pseudohyphae, and buds. In case of recurrent infection, culture must be done. What is whiff test? Doctor uses KOH to detect which type of infection through putting 2 drops of KOH with concentration of 10% on event culture and detect the type of infection through color and odor. Recurrent bacterial vaginosis. It is defined as 3 or more episodes in 12 months. Recurrence rate is high and often involves frequent telephone calls and visits to the clinic. Multiple treatments are prescribed in the absence of curative therapy. Bradshaw et al. Reported recurrence rate of 58% over a 12-month period in women treated with oral nitronedazole for 7 days. In their study, recurrence was associated with prior history of bacterial vaginosis, lack of hormone contraceptive use, having the same sexual partner throughout the study duration, and having female sexual partners. The repetition rates as high as 30 to 50% within 3 months is designated as recurrent bacterial vaginosis. Other factors that have been associated with recurrence include dowsing, frequent sexual intercourse without using condoms, and failure to re-establish a lactobacillus predominant vaginal flora. It has also been suggested that formation of a vaginal biofilm in bacterial vaginosis could be one of the factors in recurrent bacterial vaginosis. Recurrent trichomoniasis. Trichomoniasis is the most common non-viral sexually transmitted infection in women worldwide. Cases of recurrent trichomonas vaginalis have also been reported with recurrence rates as high as 5 to 8% within 2 months of initial diagnosis. It is associated with reproductive morbidity and increased risk of HIV acquisition and transmission. Patients may be asymptomatic or present with abnormal yellow-green vaginal discharge, inflammatory symptoms such as itching, burning, and dyspareunia. On examination, there may be erythema of the vulva, vagina, and strawberry cervix. Microscopy, if available, may reveal motile trichomonas. Other diagnostic modalities include point of care testing or FDA approved commercially available molecular testing. Among these is nucleic acid amplification testing is recommended for diagnosis of trichomoniasis. Recurrent vulvovaginal candidiasis. Recurrent vulvovaginal candidiasis is defined as at least 3 symptomatic episodes in 12 months. Risk of recurrence is increased in patients who frequently take antibiotics or chronic users of corticosteroids or prolonged use of immunosuppressant drugs and immunosuppressed patients with uncontrolled HIV and AIDS, have uncontrolled or poorly controlled diabetes, or have azole resistance or non-candida albicans vulvovaginal candidiasis. What are the risk factors for recurrent vaginal candidiasis? Host factors include impaired glucose tolerance, diabetes mellitus, broad spectrum antibiotics, contraceptive pills, pregnancy, use of spermicidal jellies, steroid therapy, immunodeficiency, mechanical irritation. Yeast factors include virulence, ability to evade vaginal epithelium, protease production increases invasiveness, and germ tube formation increases adherence. Skin conditions misdiagnosed as recurrent vaginal candidiasis. They include irritant contact dermatitis, vulval vestibulitis, bacterial vaginosis, genital herpes, physiological discharge, tinea cruris, psoriasis, and lichen planus. What are the complications? Pelvic inflammatory diseases, HIV infection, persistent discomfort, and infertility. During pregnancy, risk of miscarriage, risk of preterm birth, Risk of preterm rupture of membranes and risk of low birth weight and post-abortion endometriosis is also seen in some cases. Trichomonas vaginitis. Recommended regimens for the treatment of Trichomonas vaginitis include metronidazole 2 grams orally in a single dose or tinidazole 2 grams orally in a single dose. The cure rate in treating trichomoniasis using oral metronidazole is 90% to 95%. In resistance cases, oral metronidazole may be repeated after 4 to 6 weeks. Alternative regimens include metronidazole 500 milligrams orally twice a day for 7 days. Trichomonas vaginitis. Follow-up is unnecessary for men and women who become asymptomatic after treatment or who are initially asymptomatic. Management of partners. Partners of patients with Trichomonas vaginalis should be treated. Patients should be instructed to avoid sex until they and their sex partners are found to be negative. Trichomonas vaginalis. Special considerations like pregnancy. Vaginal trichomoniasis has been associated with adverse pregnancy outcomes, particularly premature rupture of the membranes, preterm delivery, and low birth weight. However, data do not suggest that metronidazole treatment results in a reduction in perinatal morbidity. Women may be treated with 2 grams of metronidazole in a single dose. Metronidazole is pregnancy category B drug. Recurrent trichomoniasis. In women who fails to get rid of trichomoniasis with 2 grams of metronidazole without evidence of reinfection, metronidazole 500 milligrams orally twice daily for 7 days is recommended. If treatment fails, tinidazole or metronidazole 2 grams orally for 5 days is then recommended. If persistent infection is documented despite the previous therapy without evidence of reinfection, there are case series and reports documenting success using high-dose tinidazole and a compounded paramomycin in management of refractory trichomoniasis as follows. Tinidazole 500 milligrams orally 4 times daily for 1 week or tinidazole 500 milligrams orally 4 times daily plus tinidazole 500 milligrams vaginally twice daily for 14 days or tinidazole 1 gram orally 3 times daily plus 5 grams of compounded 5% intravaginal paramomycin for 14 days. Vulvovaginal candidiasis. Treatment for uncomplicated vulvovaginal candidiasis. Short course of topical formulations. Example, single dose and regimens of first dose and third day dose effectively treat uncomplicated vulvovaginal candidiasis. The topically applied azole drugs are more effective than nystatin. Treatment with azoles results in relief from symptoms and negative cultures are observed in 80 to 90% of the patients with the completion of therapy. Vulvovaginal candidiasis. Recommended regimens for uncomplicated vulvovaginal candidiasis include intravaginal agents like butoconazole 2% cream 5 grams intravaginally for 3 days or clotrimazole 1% cream 5 grams of it intravaginally for 7 to 14 days. Clotrimazole 100 milligrams vaginal tablet for 7 days. Miconazole 2% cream 5 grams intravaginally for 7 days. Oral agent. Fluconazole 150 milligrams oral tablet, 1 tablet in single dose. Vulvovaginal candidiasis. Complicated vulvovaginal candidiasis. Recurrent vulvovaginal candidiasis. It is usually defined as 4 or more episodes of symptomatic vulvovaginal candidiasis in 1 year. Affects a small percentage of women, that is less than 5%. The pathogenesis of recurrent vulvovaginal candidiasis is poorly understood, and the majority of women with recurrent vulvovaginal candidiasis have no apparent predisposing or underlying conditions. Vaginal cultures should be obtained from patients with recurrent vulvovaginal candidiasis to confirm the clinical diagnosis and to identify unusual species, including non-albicans species, particularly Candida glabrata. Recommended treatment. A longer duration of initial therapy, example, 7 to 14 days of topical therapy or 100 milligrams, 150 milligrams, 200 milligrams of oral dose of fluconazole every third day for a total of 3 doses, that is on day 1, day 4, day 7. Maintenance regimens. Oral fluconazole 100 milligrams, 150 milligrams or 200 milligrams weekly once for 6 months is the first line of treatment for maintenance therapy. Vulvovaginal candidiasis. Complicated vulvovaginal candidiasis. Severe vulvovaginal candidiasis. Severe vulvovaginal candidiasis, that is, extensive vulval erythema, dermal excoriation, and fissure formation. It is associated with lower clinical response rates in patients treated with short courses of topical or oral therapy. Either 7 to 14 days of topical azole or 150 milligrams of fluconazole into sequential doses. That is, second dose 72 hours after initial dose is recommended. In compromised host, women with underlying debilitating medical conditions, example, those with uncontrolled diabetes or those receiving corticosteroid treatment, do not respond as well as to short-term therapies. Efforts to correct modifiable conditions should be made, and more prolonged conventional antimycotic treatment is necessary, that is for 7 to 14 days. In pregnancy, vulvovaginal candidiasis frequently occurs during pregnancy. Only topical azole therapies applied for 7 days are recommended for use among this pregnant. Recurrent vulvovaginal candidiasis. Patients with recurrent vulvovaginal candidiasis would benefit from maintenance therapy after the induction treatment phase has been successfully completed. Those with azole-resistant Candida albicans should have sensitivity testing performed and be treated based on the results. Sobel et al. And Markson et al. Have documented success with compounded medications in patients with azole resistance and those who have failed multiple doses of first-line medications. In patients with azole-resistant vulvovaginal candidiasis, treatment options include intravaginal boric acid 600 milligrams daily for 14 to 21 days, intravaginal 15.5% flucytosine vaginal 5 grams for 14 days, and intravaginal amphotericin B 50 milligram vaginal suppository daily for 14 days. Recommended regimens for recurrent vulvovaginal candidiasis include fluconazole 150 milligrams orally every 72 hours for 3 doses, followed by fluconazole orally 150 milligrams weekly for 6 months, or miconazole 1200 milligram vaginally weekly for 6 months. For patients who prefer vaginal route for maintenance therapy, miconazole can be used. Itraconazole 200 milligrams orally twice daily 3 days, followed by itraconazole orally 100 to 200 milligram daily for 6 months. Bacterial vaginosis treatment. All women who have symptomatic disease require treatment. Recommended regimens for non-pregnant women include metronidazole 500 milligram orally twice a day for 7 days. Metronidazole gel, 1 full applicator intravaginally once a day for 5 days. Clindamycin cream, 1 full applicator intravaginally at bedtime for 7 days. Bacterial vaginosis follow-up. Follow-up visits are unnecessary if symptoms resolve. Because recurrence of bacterial vaginosis is not unusual, women should be advised to return for additional therapy if symptoms occur. Management of partners. The results of clinical trials indicate that a woman's response to therapy and the likelihood of relapse or recurrence are not affected by treatment of her partner. Therefore, routine treatment of both the partners is not recommended. Bacterial vaginosis treatment. All pregnant women who have symptomatic disease require treatment. Recommended regimens for pregnant women include metronidazole 250 milligrams orally 3 times a day for 7 days or clindamycin 300 milligrams orally twice a day for 7 days. Bacterial vaginosis, follow-up of pregnant women. Treatment of bacterial vaginosis in asymptomatic pregnant women who are at high risk for preterm delivery might prevent adverse pregnancy outcome. Therefore, a follow-up evaluation 1 month after completion of treatment should be considered to evaluate whether therapy was effective. Recurrent bacterial vaginosis. Women with recurrent bacterial vaginosis should be appropriately treated based on the guidelines provided by the Centers for Disease Control and Prevention. Recommended conventional therapy of nitroimidazoles or clindamycin administered orally or vaginally and offer additional suppressive therapy with metronidazole gel twice weekly for 4 months. In a multi-center study, Sobel et al. Randomized patients with recurrent bacterial vaginosis to twice weekly intravaginal metronidazole gel or placebo for 16 weeks after initial treatment. He documented that during 28-week follow-up, recurrence was less in the suppressive therapy group. Recurrence occurred in 51% of treated women compared with 75% of women receiving placebo. Patients should be educated about the risk of possible yeast infection during the suppressive therapy phase. Another option for recurrent bacterial vaginosis is a combination of oral nitroimidazole with intravaginal boric acid as the induction phase, followed by suppressive therapy. Richmond et al. Treated women who met criteria with either tinidazole or metronidazole orally twice daily for 7 days, followed by intravaginal boric acid 600 milligrams at bedtime for 21 days as the induction phase. Asymptomatic patients then proceeded to the maintenance phase of intravaginal metronidazole twice weekly. In this study, the cure rate was 92% at 7 weeks, 88% at 12 weeks, and 50% at 36 weeks. We have modified the suppression therapy in our clinical practice and documented success with metronidazole intravaginal gel once a week for 4 months. Bacterial vaginosis recurrence rate 1 month after therapy is 20 to 40%. Recurrence may be a result of persistence of bacterial vaginosis, associated organisms, and failure of lactobacillus flora to recolonize. Twice weekly metronidazole gel for 6 months may reduce recurrences. Key points to be kept in mind are recurrence is very common. Treatment attempts to decrease anaerobes and yellow lactobacilli to repopulate. No other approaches to enhancing recolonization of lactobacilli has been shown to be effective. Example, yogurt therapy, exogenous lactobacillus treatment, etc. Current treatment options available for bacterial vaginosis. Antibiotics, antifungals remain mainstay of therapy. The recurrence rate is high and associated with side effects. Probiotics. These are live microorganisms which, when administered in adequate amounts, confer a health benefit to the host. Main types of microbes which are used as probiotics are lactic acid bacteria and bifidobacteria. They are commonly found in fermented foods. Live cultures are usually added. yogurt, dietary supplements. Probiotics containing lactobacillus are used over a long period, used as an alternative to antibiotics, particularly within the context of high infection recurrent rates. Possibility of harnessing specific bacterial strains in order to prime the vaginal microbiota in the pre and periconceptual periods. What are prebiotics? Prebiotics are the compounds in food that induce the growth or activity of beneficial microorganisms. What is symbiotics? Combination of prebiotics and probiotics is called symbiotics. What are the actions of prebiotics? They stimulate the growth and reproduction of only useful microflora. They maintain an optimal pH in the intestine. They stimulate local immunity. They remove excess mucus from the walls of the small intestine. They reduce the formation of gases. They suppress the reproduction in the intestine of pathogenic bacteria. They stimulate peristalsis, improve the work of the digestive system. Mechanism of actions of probiotics and prebiotics. At the level of intestinal microbiota, at the level of intestinal epithelial cells, and at the level of intestinal mucosa vessel. Lactobacillus and Bifidobacterium at the level of intestinal microbiota, they competition and cooperation with the nutrients and they helps in bile metabolism. They produce antimicrobial compounds against pathogenic microbiota and by competitive exclusion they help in eradication of pathogenic bacteria. At the level of intestinal epithelial cyst where innate system is actually working, they have a role in metabolic interaction and barrier function of the epithelium. They also cause anti-apoptosis and tight junctions and induction of mucins, etc. Intestinal mucosa, where adaptive immune system works. Lactobacillus and Bifidobacterium will cause regulation of cytokine expression, modulation of phagocytosis, modulation of IDC maturation, and modulation of T cell differentiation, etc. All these actions will lead to the characteristic features of potential probiotics like acid and bile stability. They are human origin and production of antimicrobial substances and adherence to the human intestinal cells, persistence in the human intestinal cells, clinically validated and documented health benefits, antagonism against enteric pathogens, susceptible to antibiotics and safety in food and clinical use. Restriction of usage. Restriction of probiotic usage should be considered in some of the conditions. What are the major concepts that have been investigated include bacteremia, adverse immunological effects, antibiotic resistance transfer, potential transmigration that is bacteremia. It is diagnosed with immunosuppressive patients in prior prolonged hospitalized patients and prior surgical intervention cases. Immunological effects, there are no clinical proofs regarding this. Antibiotic resistance transfer. Plasmid in lactic acid bacteria. There is a possibility of transfer of a tetracycline resistance plasmid. 14 strains were tested, only 7 transferred resistance to Enterococcus, 2 transferred resistance to Lactococcus lactis, and none were able to transfer resistance to Staphylococcus aureus. Who to watch for? While using probiotics, generally say but though these patients should be monitored with using when we are using probiotics. They are immunocompromised patients, premature infants, patients suffering short bowel syndrome, those with central venous catheters, elderly and patients with cardiac valve disease. Infection control. Why probiotics are used for infection treatment? New problems created by antibiotics Disruption in antibiotics will disturb the protective flora also. Antibiotic resistance due to the abuse and overuse of antibiotic prescriptions, running out of antibiotics, and interest in the uses of ecological methods instead. Vaginal probiotics. Rationale to develop. Clear hypothesis about role of lactobacilli. Clearly established protective role of lactobacilli. Lactobacilli are predominant in the vagina. Application can be topical, reaching high inocular, no organoleptic considerations. Easy to perform clinical trials, easy sampling, easy reuse of probiotic lactobacilli after application already available. Rationale of probiotic using lactobacilli. Develop a non-chemotherapeutic probiotic therapy using lactobacilli to maintain healthy lactobacilli-dominated vaginal flora. It helps protection from sexually transmitted diseases and it helps in preventing preterm labor. It improves the quality of life of a woman when inserted directly into the vagina. Oral preparation will work from gut to vagina. Used in women prone to urogenital infections during infection, but also for healthy women to maintain normal flora. Rationale of probiotic using lactobacilli. In women prone to urogenital infections or during infection, in healthy women as a prophylaxis to maintain normal flora, lactobacilli probiotics can be used over a long period without adverse effects like antibiotics. Probiotics versus antibiotics. Antibiotics damage commensal microflora, can increase the occurrence of resistant bacteria, can have adverse side effects. Probiotics can be used in adjunction to antibiotics to restore the commensal microflora. Ideal treatment. They provide Indian genome specific strains, vaginal specific strains, maximum colony forming units 10 billion colony forming units. Biological control of vaginosis to improve reproductive health. The human vaginal microbiota plays an important role in the maintenance of a woman's health as well as of her partners and newborns. When this predominantly lactobacillus community is disrupted, decreased in abundance, and replaced by different anaerobes, bacterial vaginosis may occur. In bacterial vaginosis, the overgrowth of anaerobes produces noxious substances like polyamines and other compounds that trigger the release of pro-inflammatory cytokines like interleukin 1 beta and interleukin 8. Bacterial vaginosis can profoundly affect, with different mechanisms, all the phases of a woman's life in relation to reproduction, before pregnancy, during fertilization, through and at the end of pregnancy. Bacterial vaginosis can directly affect fertility, since an ascending dissemination of the involved species may lead to tubal factor infertility. Exogenous strains of lactobacillus have been suggested as a means of re-establishing a normal healthy vaginal flora. Carefully selected probiotic strains can eliminate bacterial vaginosis and also exert an antiviral effect, thus reducing viral load and preventing fetal and neonatal infection. The administration of beneficial microorganisms called probiotics can aid recovery from infection and restore and maintain normal flora. Abnormal vaginal microbiota may be associated with poor reproductive outcomes, a prospective study in IVF. Summarized shows the vaginal microbiota of IVF patients can be characterized with qPCR test, which may be promising tools for diagnosing abnormal vaginal microbiota and for prediction of clinical pregnancy in the IVF treatment. Why strains of native origin are used in preparing probiotics? Products with strains of Western origin, which may not have the same benefit to the patient. as native origin. It is now widely accepted that native strains will have better efficacy on the local populations. Product should have the advantage that all the strains are of native origin with clinical study and safety validated in Indian populations in establishing efficacy. What are the right combination of lactobacilli? Identification of cultured vaginal lactobacilli using DNA PCR test. Most commonly seen bacteria are Lactobacillus crispatus and Lactobacillus jensenii, Lactobacillus gasseri, and Lactobacillus iners. Treating bacterial vaginosis increases pregnancy rate. European Journal of Obstetrics and Gynecology and Reproductive Biology, through a study, confirmed that treatment doubles pregnancy rate. In untreated patients, the chances of pregnancy is only 20%. If the treatment is given, then the pregnancy chances are increased to 49%. Use of probiotic strains for the treatment of bacterial vaginosis. Type of intervention and probiotics used. Treatment of bacterial vaginosis only with probiotics. What are the different modalities? Are vaginal capsules containing 10 to the power of 9 colony forming units of Lactobacillus acidophilus or placebo for a period of 6 days. And vaginal capsule introduced 1 to 2 times daily containing Lactobacillus acidophilus and estradiol for 6 days. Another regimen includes daily vaginal capsules containing Lactobacillus rhamnosus and Lactobacillus reuteri twice a day metronidazole gel for 5 days. Another regimen includes vaginally introduced 1 to 2 capsules daily containing Lactobacillus brevis, Lactobacillus salivarius, Lactobacillus plantarum for a period of 7 days. Treatment of bacterial vaginosis with probiotics in combination with antibiotics. There are different modalities as follows. Vaginally introduced 100 milligrams of clindamycin for 3 days. Subsequently, tampons containing Lactobacillus gasseri, Lactobacillus gasseri rhamnosus, Lactobacilli fermentum, or placebo tampons during the next menstrual period. Another regimen include oral intake of 500 milligrams of metronidazole for 7 days and oral probiotic capsules containing Lactobacillus rhamnosus, Lactobacillus reuteri, or placebo for 30 days starting from day 1 of the metronidazole treatment is another regimen. Oral intake of 300 milligrams of clindamycin for 7 days followed by vaginal capsules containing Lactobacillus gasseri rhamnosus for 7 days. Another regimen includes vaginal cream containing 2% clindamycin followed by vaginal capsules containing Lactobacillus gasseri and Lactobacillus rhamnosus. The probiotic treatment was performed and subsequently repeated for 10 days after each menstruation during 3 menstrual cycles. Treatment with a single dose of tenidazole plus either 2 oral capsules of Lactobacillus rhamnosus, Lactobacillus reuteri in the morning for 28 days starting in the first day. Oral 500 milligrams of metronidazole followed by vaginal application once a week for 6 months of a capsule containing 40 milligrams of Lactobacillus rhamnosus beginning 8 days after the metronidazole therapy. Another regimen includes oral intake of 400 milligrams of metronidazole for a period of 7 days followed by vaginal pessary containing Lactobacillus acidophilus and estradiol for 12 days. So, with this, I wanted to conclude my session.
Thank you. Thank you very much, madam, for the session. Just give me 1 minute time to check the questions, if any, in our dashboard.
Yeah, sure.
The first question is there means what is the treatment protocol in case of vaginal infection in case of this means late period of pregnancy?
Late period of pregnancy.
Yeah, meant late stages.
Depending upon the complaints with which the patient is presenting, we have to inquire regarding the history. This is the first time or any recurrence she is having complaints. We have to inquire from history. And any modifiable conditions like any obesity, any GDM, we have to identify depending upon the external examination and internal examination and examination of the vaginal discharge by checking wet mouth preparations and checking the pH of the vaginal discharge. So any external signs and symptoms, depending upon all these, we have to confirm which microorganism is causing the vaginal discharge. Most commonly, Candida and Trichomoniasis we commonly see in the late trimester of pregnancy. So, depending upon the which type of organism, if it is Candida, we have to treat locally with topical azole drugs. I prefer to use fenticonazole tablets. Recently, they are showing good results in the basis of 137 like that. If she is a first time, there is no recurrence, no history, previous history, then we can use 2 doses on first day and third day. If she is having recurrent symptoms, then we have to use probiotics and we have to use oral fluconazole drugs on day 1, day 3, day 7. So depending upon the symptoms wise and previous history wise, we have to decide and treat. If it is a case of trichomonas, if we suspect, we have to use metronidazole 2 grams or tinidazole 2 grams. And if she is having any history of preterm deliveries in previous cases, or she is showing any signs of preterm deliveries, any IUG or any symptoms, malodorous discharges like that, if she is having multiple partners, any other risk factors, we have to continue the treatment, that is suppressive therapy. Initial therapy, aggressive therapy, followed by suppressive therapy in the form of weekly once metronidazole or twice weekly metronidazole gel, depending upon the severity of the symptoms till term, and the use of vaginal probiotics, we can advise them. And you should advise them regarding what she is taking, whether she is taking regularly her medication or not, whether she is in any stress conditions, any obesity, any modified conditions, we can decrease personal high maintenance of, we have to educate them regarding the personal hygiene and advise them not to use any tampons or any other products, scented products like that. We have to inquire them what might be the underlying cause. We have to inquire and advise them. So personalized treatment, individualized treatment should be planned.
Thank you very much, madam, for the nice deliberation. So, ma'am, I could not find any other question. So, thank you once again for your valuable time on our platform Shield Connect and for such a nice discussion on this emerging topic. So, in future also, I will look forward for some valuable session with you, madam.
Thank
So,
you,
thank you,
Shield
thank you,
people,
thank you.
for selecting me and giving me this opportunity to share my opinion and my experience to you all. Thank you, friends.
Thank you very much, madam, and have a good day.